Hi everyone, welcome to researchmd.com. We got another great presentation today. We're going to talk today about HHV-3 varicella zoster virus. Remember we had given two presentations on HHV-1, herpes simplex 1 and herpes simplex 2 previously. So today we're going to focus on varicella zoster virus, HHV-3. Okay, again, my name is Pramil Cheriyath. I'm a program director, internal medicine residency, transitional residency. I teach medical students and residents. I'm also director of research and assistant professor of medicine, two major medical schools in the US. So let's get into our topic. So when you talk about varicella zoster virus, that belong to the alpha herpes virus family called human herpes viridae or HHV-3. Okay, primary infection, if in children, you can pretty much call as like a chickenpox, and this virus is again responsible for chickenpox and herpes zoster, or people call it shingles. So the next thing is like, we have to look at the structure of the virus. Structure of the virus, you got the core, consists of single linear molecule dsDNA, okay? And then we have the capsid surrounding the core. It's an icosahedral capsid with consists of 162 capsomeres. And between the core and capsid, you have this tegment, which is that asymmetrical, and it consists of viral enzymes. And then you got envelope surrounding, that's the outer layer of the virus. Okay, and now let's look at this called chickenpox in the children. Most cases occurs in the children. It can happen and also in the adult, but it's very rare. Worldwide distribution. Reported incidence around 13 to 16 per 1,000 per year. A little bit of epidemiology. Before widespread varicella zoster vaccination, estimated 4 million cases annually. Because of the vaccination, it's been coming down. So what are the risk factors? Close or direct contact with the infected individuals. And age, if it is less than 1 and greater than 15 years, and immunocompromised. That's like an important point. If you're immunocompromised, and the complications also very high, if there is like congenital immunodeficiency, or the patient have like transplantation, you have to worry. Now, transmission through contact with the infected person by inhalation of the respiratory droplets, or aerosol generated by skin lesions, direct contact with the droplets or vesicular fluid from the skin lesion, and it can happen in blood transfusion, even though it's like very rare. And the transmission can occur from 24 to 48 hours before the exanthem begins until the pustular stage. Okay, so before, you have to once the patient, before the exanthem begins, that 24 to 48, the prodromal phase is very contagious. And the person with herpes zoster rash may transmit varicella zoster virus, primarily varicella in susceptible persons. Also remember that. Now, let's look at the pathogenesis. When you look at the pathogenesis, mainly you got the virus kind of enter through to the oropharynx, and it kind of first thing is going to go to the T cells, okay? And then T cells enter the circulation, and then it replicate in the skin lesion. That's where the most of the replication happens. And then what happened? You have to worry about the latent stage. So they kind of go into and hide in the cranial nerve ganglia, dorsal root ganglia, and autonomic ganglia along the entire neuraxis, and that is the pathogenesis. So what are the signs and symptoms? So incubation, typically 14 to 16 days, okay? May even take like 21 days. So it's long incubation period. You got the vesicular pruritic rash, and before that you can have fever, malaise, headache, and abdominal pain. Kind of watch out the prodromal symptoms, okay? And the common features, this classic cutaneous lesion. Usually begins on the head and trunk, and then it kind of go to your extremities, and then pruritic lesions first appear, erythematous macules, and finally you can see the small fluid-filled vesicles are there. New lesion formation ranges from 1 to 7 days. It may appear several crops or lesions throughout the body, like various stages. A number of vesicles, usually anywhere from 250 to 500, and some people can have like almost like a greater than 1,000 vesicles, okay? In the final stages, lesion develop crust, and hypopigmentation is common during the healing. Remember, in the healing process and everything kind of crusted together. Now, In the adults and immunocompromised patient, it may be characterized. It's going to be prolonged fever, numerous development of lesions, longer new lesion formation in the adult and the immunocompromised people. And the diagnosis, mainly, the clinical diagnosis, generalized pruritic vesicular rash and fever, which is classic, and lab tests, not necessarily. But if you need to do what are the lab tests, you can do it to confirmation, okay? Laboratory confirmation may be needed in rare cases. Let's see what circumstances you need to do, like an expensive lab test to confirm this. Atypical disease presentation, absence of rash or disseminated zoster, suspected case of breakthrough varicella. You got zosteriform like herpes simplex, rashes caused by enterovirus, poxvirus, rickettsia, drug reactions or contact dermatitis, and confirmation of VC infection as a cause of an outbreak, and then establishing VC infection in the cause of death, and determining susceptibility to varicella and suspected drug-resistant VCV infection in the immunocompromised individuals, okay? Now, let's look at, we need to know what are the tests. One is like PCR. Look at the sensitivity and specificity, 94%, and specificity is 100%, okay? Now, the next text is you can do direct immunofluorescence test. It also have like high sensitivity and specificity, 87.8 to 93.8%. So what are the complications you can expect from like varicella? You can always kind of worry about secondary infection, like Staph aureus, streptococcus, pneumonia, hemorrhagic condition like purpura, thrombocytopenia. You can have like a neurological complication. You got perinatal complication. You can have rare ocular manifestations also. Herpes zoster is a late complication or reactivation of after a latent period. After several years, it can appear and cause zoster. So the treatment, usually like symptomatic treatment, acetaminophen is a good idea. You can use soothing creams and anti-itching medication like maybe oral antihistamines, diphenhydramine, loratadine, and fluid and electrolyte. Make sure you prevent the dehydration in this patient, okay? Treatment-wise, acyclovir is one of the most common drug we use to treat, right? If the person is greater than 12 years, never been previously vaccinated, you can give. People with chronic cutaneous pulmonary disorders, you can give. Recipients of long-term salicylate therapy and immunocompromised people, you can give. And indication of acyclovir and other antiviral therapy in adults include severe varicella, the pregnancy, again, immunocompromised, chronic skin or lung disease, okay? So prognosis, most cases is self-limited. Everybody knows that. In pregnant women, increased risk of severe complication like maternal death and adverse fetal neonatal outcomes, so be careful. Mortality reported up to 10% of severe immunocompromised individual, and 30% of case of neonatal varicella increase in case of adult varicella. Okay? Thank you so much for watching. We'll be back with another presentation. Please subscribe to our channel.